Ready? We'll go live here soon. All right. Well, welcome everyone. Thank you so much for joining us. This is our new annual AAST SCCPDS Fellowship Town Hall. We've been doing this for a few years, and every year seems to get better and better and better. We are super excited for this year's panel, topics, and flow, and we're super excited to get started. My name is Joshua Dilday. I'm the chair of the AAST Associate Member Education Committee, and I'm joined by a couple of my colleagues and many esteemed guests and leaders in the field who will have the opportunity to discuss really the basics of fellowship application process, tips and tricks. How do you know if you're applying for the right program? And what are the differences between the programs? A lot of these information is extremely relevant as the match is quickly coming up. The application process is quickly coming up. And we're excited to offer this product every single year. Without further ado, I'll introduce our main moderator, Dr. Yuhavich, and he is going to get us started with introducing the rest of the panelists, and we'll get underway. This is a webinar-based product, so will be recorded. If you do have questions, there's a chat function in which you can respond to your questions immediately in the chat. Some of those questions we can answer directly live while the speakers are going, and some of the questions we can flag for discussion at the end. So without further ado, Milos, take it away.
Good afternoon, everybody. Thank you so much for joining us. I'm just going to pull these slides up so that I can go through our introductions. We are... Maybe it doesn't want to go through the slides. Everybody see that?
There we go.
There you go.
It is a pleasure for me to welcome everybody to our Fellowship Town Hall, which is jointly organized by the AAST Associate Members Committee and the Society, the Surgical Critical Care Program Directors Society. We have a who's who of senior leadership from the field of surgical critical care, as well as some current fellows who will be able to answer some of your pressing questions. Our first speaker today is Dr. David Spain. He is a professor of surgery at Stanford, former president of the American Association for the Surgery of Trauma, as well as a past counselor of the ABS and director of the Surgical Critical Care Boards. He's also the program director for the general surgery residency at Stanford and has been giving our sort of keynote lecture for this fellowship town hall for the last several years. We're also honored to be joined by Dr. Niels Martin, who is an associate professor of surgery at the University of Pennsylvania and the chief of the Division of Trauma, EGS, and Critical Care. Dr. Martin offers a plethora of surgical critical care 1, 2-year and ER opportunities for those of us in the crowd that are interested in all the different avenues. And as you can see, like Dr. Spain, he serves on multiple boards and is in the know for all things critical care. Dr. Pauline Park also joins us today. She is a professor of surgery at the University of Michigan, the co-director of the Surgical Intensive Care Unit, as well as the program director of the Surgical Critical Care Fellowship. Dr. Park brings expertise not only in the fellowship program, but a lot of research that she has done for mechanical ventilation and surgical critical care for those of you that are interested in the research track that comes along with surgical critical care and acute care surgery. Joining me on the panel today, along with Dr. Dilday, we're honored to have Dr. Krista Kaups, who is a professor of surgery at UCSF Fresno. She's the director of the ICU and a 19-year veteran of the Surgical Critical Care Fellowship world. And she's the immediate past president of the Surgical Critical Care Program Directors Society, the incoming president of the Western Trauma Association, and my boss on the AAST Patient Assessment Committee. Also joining us on the panel, we're honored to have Dr. Laura Haynes, who is a associate professor of surgery at UC San Diego. She is the director of the Surgical Intensive Care Unit, the program director for the Surgical Critical Care and AAST ACS Fellowship, and the current chair of the SCCPDS Communications Committee. Dr. Dilday, who is our vice chair. This slide made it on there even though it shouldn't have. So anybody that wants some extra information about Dr. Dilday, have a quick read through that. I apologize for embarrassing him. And we're also very fortunate to be joined by two fellows. Our first year fellow who is at USC in LA County is Dr. Natalie Hodges. She completed her residency at Texas Tech University Health Science Center and is in her first year of 2 years of fellowship. And also Dr. Devin O'Connor, who is a current second-year fellow at the University of Arizona, who completed his residency at Creighton University. So without further ado, I'd like to pass it over to Dr. Spain to get us underway with how to find your fit.
All right, thank you. All right, let's see. Good afternoon, everybody. Glad to be here. I'm going to take a few minutes to talk a little bit about finding your fit. I was telling the people beforehand I have a whole longer talk about this. It could be a whole hour, but I want to talk just about some of the highlights that I think are important to start thinking about. So there are a lot of programs out there, and every year there's a little bit more. We're now up to 173 programs with 358 spots. When we started this years ago, there were like 50 people a year going into surgical critical care, and now it's like 300, residents a year are going into surgical critical care. There's about 1,500 or so graduates a year. So that's, 1 out of every, 5 or 6 residents are now going into surgical critical care, which is pretty impressive. So again, lots of programs out there, lots of options, lots of positions, pretty good match rate, more than 95%. And again, roughly 95% of people in the match get a position. So lots of good options out there. So your chances of matching are pretty high. So, I think part of the question is why, why all this interest? Like, why is this, going on? We're now up to about 300 people a year going into surgical critical care, 1 out of every 6 graduates. We did a survey a couple years ago. I have to think this is one of the things we did in the last couple of years that I was sort of most proud of and excited. So we basically asked everybody, like all of you who are in fellowships and just completed fellowships, why? What was the sort of driving this interest in acute care surgery and surgical critical care? And we all had different hypotheses going in. And the fact of the matter is, the most common answers were I want to develop a broad skill set. I enjoy complex problem solving, and I like taking care of sick patients. And to me, this was very reaffirming, because this is all the reasons I went into the field 30 plus years ago. And it's great to see that kids these days, right, still want to do the same stuff we did, right? Want to take care of the sickest patients in the hospital and be really seen as the person that will step up to the plate and take care of the most challenging problems. So I found this very heartening. So there are a lot of programs out there, right? You're going to hear a little bit more about 1-year programs, 2-year programs. There's a whole bunch of different 2-year programs out there. Some of them are AAST approved, acute care surgery fellowships. Some are a little bit more the old-fashioned kind of trauma fellowships. Some are highly variable. They structure the second year to sort of and individualize it to meet your needs. So there's some that are very research intensive. Our second year has kind of been that way. We're sort of morphing towards a AAST fellowship right now. Other ones have focused on administration. If you want to be a trauma medical director, how do you do that? And others have just focused straight up on sort of clinical care and teaching. All of these are valuable. All of them are needed. It's a question of sort of figuring out which one of these makes the most sense for you and adds to your skill set. So again, I think the couple big questions are the hospital type and a little bit of location. So, most fellowships are in sort of either an academic medical center, tertiary care center, or probably like a trauma dominant kind of county or city hospital. So like at our place, we're a large academic medical center. We have, cardiac surgery and transplant and, all this stuff going on. Whereas if you go to our county hospital, it's kind of trauma dominant. So you can find all sorts of different possibilities and combinations out there. And then again, you got to think about where you want to live. Like most of these places, since they're at level 1 trauma centers, are going to be urban or suburban, but there may be some that are a little bit more, community located. And then the question, where do you want to live? Like what part of the country do you want to live in? Does it matter? Where's your support system? Where's home? Does any of this stuff matter? Or are you just going to go to the best place you can find? So, one of the things I will, again, regardless of like what exact position you take, like one of the things I want to push people on is this idea of thinking about pushing through your limits. So, part of the fellowship is about growing and adding skill sets. So you have to be comfortable with being uncomfortable. So you gotta, be willing to be pushed a little bit. Like I don't know what the future holds, especially right now. Jesus, just like chaos out there right now. I don't know what it's gonna look like in 3 or 4 years. But you can't let fear of change sort of lead you into paralysis. So, new situations, in some ways, they can force you to grow and teach you to avoid becoming dependent on others and just taking care of yourself. So, can allow you to thrive sort of in any location or situation. So, I think the question you want to ask is will this program push me to learn new things? And that might be patient care, could be how to lead a team, could be how to be a better teacher, could be how to be a better researcher. Like, should be some combination of these things. Like, will this program push me to pick up new skills and get better at the areas that are important to me? And then that'll be a little bit different for everybody. So that's one big thing. And that's probably the most important thing that you really want to think about is how will this program push me? And then I think a little bit also is about like who's there, what kind of mentors will I add to my team, what kind of connections will I make, who are these people, who do they know, and how will they help me get a job, and how will they help me advance my career? The good news is, when I was a fellow looking through this, there were about 6 places that I think did this well, and that was about it. Now there's like dozens and dozens. It's more the rare program that doesn't do this anymore. And so I think the good news is there's tons of options out there and people that are really willing to help you. So my bottom line is don't take the easy path, right? Like push yourself. Try to think about what will this place push me to learn and do differently compared to where I was a resident. So, every single fellowship is different. If you've seen one fellowship, you've seen one fellowship. Like they're all different. So there's not going to be any definitive answers today. But we can have a good discussion about different stuff. So, we can talk about what kind of questions you should be asking programs and how they're going to help you grow. So again, there's no such thing as a dream or perfect fellowship, but you can find a great one that'll help you with your career. And then I love this quote with Bruce Lee, right? So you gotta be like water, right? So, water can do a lot of things, but you have to be fluid and willing to be flexible and change your direction when needed. All right, so that's the end of mine, and happy to help answer questions later.
Thank you so much, Dr. Spain. Before we move on to Dr. Martin and Dr. Park, I just wanted to remind all of our participants, all of our residents and future fellows, if you have questions as you hear the talks, please drop them in the Q&A so that we can address them with the panel at the end. And if we don't address them, we will try our best to address them in the actual chat itself. So if you have questions that you would like to ask at the end, please drop them in the Q&A, and I will hand over to Dr. Martin to give us some education on 2-year AAST fellowships.
Great. Thanks again for the invitation to speak and really give kind of my 2 cents on the 2-year pathway to fellowship training. I obviously will not address what was given in the previous talk or the next talk, but I will say that the concept of fit probably is even more important in the 2nd-year fellowships, because there's a lot more heterogeneity amongst 2-year fellowships than I think there is within the curriculum of the 1-year fellowships that are just focused on surgical critical care. So that's a really important piece of fit as we talk about what 2-year fellowships bring for you. So just as a way to kind of understand the two, obviously the 1-year fellowships are just critical care. 2-year fellowships give you the same critical care year, but then they add an additional year of some sort of trauma / emergency general surgery / acute care surgery training. Nomenclature is still a funny place in our field, but that's really the discrimination between the 1 and the 2-year. Obviously, for the 1-year pathways, you're a little bit quicker to practice. Many folks who do or opt for the 1 year already have a plan in place. They already have a scientific plan because they're a PhD, or they have a very specific intention of doing something in a niche space that they already have fully developed. Others that do the 1 year may have a big interest in EGS and less in trauma, and just want to have that kind of acute care surgery or surgical critical care badge that allows them to advertise themselves as an EGS surgeon. And also, many may already have a specific job in hand with mentors who can usher them through the first couple years of practice so that they are fully supported and kind of get going to where you're going. The 2-year programs provide you obviously with an additional year of developmental time. And again, these are my feelings. During my introduction, it did state that I participated in a couple different boards, et cetera, but these are my own personal views and not representative of any of the other associations that I may have. The desire for perhaps a deeper clinical understanding, developing your surgical judgment a little bit more, absolutely is something that happens during that 2nd year. It is also time to develop outside of the clinical space administratively, understanding billing, understanding trauma performance improvement, understanding how to manage your time in perhaps the similar fashion to a faculty member than as a house staff. It may be a time to develop a further research skill set. And very often you'll hear programs say that when the fellows finish that 2nd year, they go out into practice and they feel like it's their 2nd job, not their first, meaning that they have just such a comprehensive understanding of all things being a faculty member that they really hit the ground running. And perhaps it might have taken them several years to get to that point had they just gone straight into practice. And then, as was alluded to earlier, just understand that not every 2-year program is certified by the AAST, and that is something that you should ask programs as you go through. The AAST certification process started roughly, 6-7 years ago, maybe a little bit longer, and it really focused on bringing a homogeneity to the 2nd year experience. First in a rotation-based setup, but really ultimately now in a defined category case log, very similar to what you do as residents, to ensure that you have some degree of a robust and level experience in your training. And so that's something to look for as you go through. Thinking about the layout of that year, what is the value added? things that you want to understand, because again, there's a tremendous amount of heterogeneity. Is this a program that sets up rotations where you spend time on vascular and you spend time on thoracic and you spend time on cardiac and you understand all the moving parts, maybe some transplant or hepatobiliary, to really get experience in those spaces, versus how much time will you spend on the trauma service where you're actually caring for injured trauma patients, and how much of your case log is completed via rotations elsewhere versus rotations on actual trauma patients. I think you should get a sense of what are the defined category cases and how do the programs perform in those spaces. Are they meeting the case minimums? And where are they getting those cases again? Are they getting them from the rotations or from service on the trauma service? The case categories include trauma, operative and non-operative, and then EGS. Some places might send you somewhere different for your EGS experience, and those are things you should understand. The AAST also adds several other pieces to the second year experience, including journal clubs, meet the mentors, where you get to meet and participate virtually with big names in the world of trauma around the country, and a fellow on faculty member experience. There are multiple educational modules and even an in-service exam and a final exam through the AAST that just adds to the educational experience and makes it a little bit more robust. There are a lot of other activities besides the clinical work in the second year. It's how much teaching do you get? How much time do you have to develop or work on some research projects? And really, how much administrative knowledge do you gain in that second year? And just to briefly touch on these, you may have trained at a place that's great for trauma. You may have trained at a place that sent you elsewhere for trauma, and that's totally okay as an incoming fellow. But you want to know, if you do a second year, how robust is your clinical exposure? If you rotated somewhere that didn't do Roboa or didn't have TAG or didn't have whole blood, and that's a empty space for you, then maybe the second year will be beneficial to really level set your understanding across the board so that there are no further gaps in your comprehensive understanding of trauma, clinical judgment, or even your operative skills. So that absolutely is something that will be developed in a trauma experience in the second year, especially if you did not get that during your residency. The second year of the fellowship obviously also exposes you to a whole other host of didactic things and also perhaps other offerings. And this is a slide that I show our fellows about things that we offer, but will you finish fellowship and be an instructor for ATLS and FCCS and ADAM and ASSET? And are those skill sets that you want to take with you to your first job or your next job down the line? Are those things that you can expose to? And of course, you'll have more of an opportunity to hone those skills if you have a second year. I don't know how many of you know what this is or have ever seen a TQIP report before, but if you have not, during a second year of fellowship, you will absolutely be exposed to a lot more performance improvement training and understand how to find opportunities for improvement, how to do loop closure, and how to do projects based on this data at your local trauma center. And so again, developing a deeper administrative understanding is an absolute added value of the second year. Research time, it's much more so built in the second year, but there's certainly opportunities to do that in the critical care year as well. But again, if that's something that you want to develop further, the second year allows you to do that. The other piece is you're just exposed to a faculty, generally speaking, at a more academic place or at a place where people are thinking critically about how to educate you. And one of the other pieces that you get as you put everything else together is a deeper understanding of leadership, a deeper understanding of the different types of leadership, servant leadership, and really how to develop that emotional intelligence to lead a team, whether it's the trauma team in the trauma bay or programmatic leadership, educational leadership, etc. All of those things can be developed much more so, again, during the second year of a fellowship. And then finally, you really learn how to juggle it all, especially as kind of a junior faculty member, depending on the layout of that second year. How do you get the clinical work done? How do you still get cases done, rounds, make it to meetings, do your PI reviews, meet with students, get all your dictations done, finish writing that article, review some journals for your faculty, teach ATLS? How do you do all those things and still kind of have a reasonable balance in life? And again, I think that's a big part of what you gain in the second year of fellowship. And then finally, it is a chance to maybe develop your niche a little bit and think about what is it that's most fun for you. I just mentioned a lot of different elements of what we do as acute care surgeons, but not everyone does every single thing. And if you stop for a second and think about the faculty in the acute care surgery division of where you are training currently, there are probably no two faculty that have the same practice, that do the same exact things clinically, administratively, academically. And so think about then what's most fun for you and who would you like to become in the future? What elements of each of these things do you want to incorporate into your niche? And again, I think thinking critically about that during a second year of fellowship and really starting to create those things is a very valuable piece of that second year. I've had many basic scientists who wrote their grants out and like had them ready to go when they got to their first job, because that's what they concentrated on academically during the second year of the fellowship as well. So with that, hopefully this was helpful, and I look forward to the Q&A after we hear from Dr. Park.
Thanks, Niels. Let me pull up mine. I told the panel earlier today that there's nothing like having to follow Spain and Martin in a conference, and it's a privilege. So I'm going to talk a little bit about one-year SCC fellowships. And when I wrote my slide set the first time, I found that a lot of it was already covered by my illustrious predecessors. So I just want to say thanks to the AAST Associate Membership and SCCPDS for putting on this webinar. And then I had to just know that I put together the rest of this, hopefully to give some flow and stimulate some questions in the discussion. So this is Neil's slide that I copied, right? And this is what he basically, and this is the 1 versus 2 year paradigm. I think that most of you guys already know that. I would add, Neil's, only to this one that I think a 1 year fellowship really, it's for candidates with strong residency operative experience who are comfortable in the area that they're going to go into. And I would also echo, if they have a specific interest that they want to develop, they can absolutely hit the ground running in a 1 year fellowship. We had the most directed interview I've ever done. I had a fellowship candidate come in and say, I'm in the Air Force. I want to do large animal work. I want to meet Hassan. I want to meet Eliason. I want to meet Napolitano. And I want to end up running something in the Air Force. And she did 1 year and she did a second year basic science research, but she did the critical care part clinically. And she's at Davis with running an Air Force lab. So because they already answered everything already, I thought, well, let's see what ChatGPT has to say today. And, you know, ChatGPT doesn't say much different, right? It's, and Niels knows this is an old trick I pulled on the last talk at the Philadelphia Academy of Surgery. Well, what does ChatGPT get from scraping all of that knowledge that's out there? 1 year, the pros are quicker to path, and this is straight from the what the answer was. Quicker path to practice, focused training, cost effective, limited time for research, maybe a narrower scope. And at the 2 year fellowship, the pros would be overall more comprehensive training, perhaps, research opportunities, leadership and specialist development. And the cons would be a longer duration and potential for burnout, is what ChatGPT said. But the conclusions really, I think, come down to what Dr. Spain said, really, what are your career goals? What's your financial situation? What's your lifestyle preferences? And I could probably end here, but I figured, you know, I tried to pick some questions that weren't already answered and see if I could give a little bit of additional, I guess, input into how you're thinking about your question in terms of what will your practice look like? Will you be ready? And will you get a job after your fellowship? So I just want to say welcome to the world's greatest job for all of you. I'm glad to see so many of you on the call. I want you to recognize that the success of the surgical critical care track really not only has it increased the numbers and reflecting the interest of surgeons in training now, but it's created a critical care void in general surgery. But as general surgery chief residents grow up expecting that there's a critical care service, I see fellowship applicants tell me that the last time that they did a time in the ICU was when they were a second-year resident, and that as ACS evolves, we're really meeting that call for care of almost all of the critically ill surgical patients in the hospital. And I think that it is important to have the dedicated year of critical care to take on the needs of the ICU patient at a senior level. And I think we should all recognize what I think is a theme is that what's happening today will not be the same as 10 years from now. So what will my practice look like? Most graduates are practicing in 3 or 4 service lines, including adult trauma, sometimes burn. Some element of some practices, emergency general surgery, for sure in most, and in surgical critical care with dedicated time in a surgical, burn, cardiac, neuro ICU. What will your practice look like? This may be I guess politically, this reflects my opinion. And acute care surgery is basically complex, what we considered complex general surgery from before. This is a paper from Stanford and Dr. Spain's group, just detailing that ACS versus non-EGS, even though it's 25% of the total volume of surgery, really a lot of it is emergency general surgery, and a lot of it is trauma. And we've taken over that part of what is core general surgery. But what will your practice look like? Disruptive changes coming as well on a daily basis. Always a question of will AI replace doctors? ChatGPT did a pretty good job of predicting or copying what Niels' slide set said. There's an increased use of nurse practitioners and physicians associates just to make workforce needs. And then the robot, right? I think that the increasing presence of robotic surgery in general surgery is a real challenge for us in ACS and in trauma in particular, because we don't have the time or the ability or often the resources to dock. And as our trainees come primarily robotic and laparoscopic, how do we incorporate that into our practice? So I'm going to tell you that I don't have the answers, but the best way to predict the future is to create it. And that as the challenge for you as young surgeons is to still meet the needs of our critically ill and trauma patients as you make advances in surgery. So will you be ready? So I'm going to tell you, since most of the candidates today are in their 4th year, I think, or maybe earlier, you should make the most of your chief year. This is one of the biggest growth years of your career, and really focus, I think, in a way that I did not as a surgery resident, I have to say. But I think you guys are much more intentional about how you are learning, about what your operative experience is. I think that the COVID volumes that people were concerned about how even getting enough cases, I think those have recovered, and that it's time again for you as senior residents to focus on what your approach is. Let your attendings know what you're looking for so they can support those goals. Ask questions, take notes. How did so-and-so do it? How am I going to do it in the future? And then get feedback. And this is always hard, but it is also informative for your growth to have someone be able to give you objective feedback and something that you can take and move forward with. So will you be ready? So the truth of the matter, and one of the great things about a career in surgery, is that it is, we're not Olympic gymnasts, we're not tennis players or football players who are done when we're 30. We're starting our careers, and we will continue to grow and learn for the next several years. So the learning curve is long in surgery, and this is from Brian George's work, linking complications and general surgery with Medicare data, and just for on the left is cholecystectomy. You can see that in your first year of practice, the number of severe complications is somewhere just under 5%, and that is steady through 30 years of practice. But as you get more complex surgery, partial colectomy, you can see that the complication rate is higher with the younger surgeon, and that curve actually takes 10 years for you to peak. So one of the great things about a career in surgery is that there's continuous learning, a continuous opportunity to get better and gain experience to contribute to patient care. So I think that you should be prepared for the long haul, and know that this is the beginning of how you will practice in the future. I think you should think beyond residency and fellowship. It's important to think about the things that we didn't used to talk about. Always was about the job. I'm going to find the best fellowship or a program that I can get to do the best career I can have. But I think you need to look at where and how you want to practice. Are you comfortable with what you've already done? What else do you need to learn? You want to keep a bunch of friends and colleagues to call. John Scott used to call them the Vicryl versus Silk buddies. Someone you can phone and talk about, continue to expand your surgical practice. You want to make sure that the job you eventually take is still willing to invest in your growth, because it will continue over the next decade. For reassurance, I can tell you that no one has ever returned from fellowship to let me know that their SCC year destroyed their ability to operate as a surgeon. Will you get the job you want? So we have data on getting fellowships from SCCPDS. Niels and I took a look at this in 2022 and 2024, the total number of positions available. It's a little hard to read this table, but about 340 to 350. About 75%, 80% are one-year positions. And the remainder are two-year positions. As Niels pointed out, some are AAST, some are trauma fellowships, some are research, some are other. And you can see that the fill rate is higher for the two-year positions. But at the same time, though, you can see that the overall numbers, just by the sheer numbers of people we're training in ACS, actually at least 3 times more are doing one-year positions. And that reflects the workforce that we are training to in ACS. So the majority of positions are 1 year, and I think the responsibility for us on the educational side, both in residency and in fellowship, is to make sure that who we are training, that they're getting the what they need to be successful to serve our population in 1 year or 2 years. Will you get the job I want? So the data is pending on the outcomes, but because the SCCPDS outcome survey that Emily Fox, Krista Copps, and the rest of the SCCPDS outcomes group have done, it's in preparation for publication, so I can't show you slides of it, but I can tell you that the answer does seem like yes. There was a survey that went out at the time of surgical critical care exam in conjunction with the American Board of Surgery. I think about 30% response rate. It was representative. About 80% of the fellows were 1 year, 20% were 2 year. And the long and short of it was that while some fellows were not aware that perhaps, that there would be some question about, well, is 2 years is 2 years better than 1 year? The 100% of the fellows who answered the survey said that they were satisfied with the training they'd gotten. So I think that the answer seems like yes. And I think that the really going back to what David and Neil said is, I think finding the fit is really important. This is the primary focus, what your own experience has been, what you think that you need to get to your goals, and your family. I mean, I have seen applicants who are saying, I'm looking for only 1 year. And I think about, she said the majority of fellows, again, were looking for 1 year or it didn't matter. 18%, I think, was the number that were looking for 2. But I've had fellows who applied to all fellowships, 1 and 2 years, within a geographic area they wanted to be in, and fellows who chose only 1 year, only 2 year. You want to look at your goals. What's most important to you? Always think ahead to what is after fellowship, and then think about it again. Because at this point in your life, I think you don't need to think in terms of right or wrong choices. You want to think about the experience gained and trying to pick the best path to go forward, because there's really opportunity everywhere. I think, as Neil said, there's a certain amount of customization that occurs in all fellowships. I think if it's amazing that if a fellow gets a job that is going to be running an ECMO program, they're out there cannulating everybody, and they're in the office looking for financial information. I have a fellow who's on a Fogarty in Ghana right now. I think that I think that you should look at what the things that you are looking for, and look at the programs in that light. And so, thank you very much for your time.
Thank you so much, Dr.
I'm gonna
Park,
try to get out of this here.
Dr. Martin, Dr. Spain. Fantastic talks. I'm sure all of our participants are indebted to you for this primer into, taking the first steps into joining the Surgical Critical Care Acute Care Surgery Club. I'm gonna pose our first question to Dr. Kalps and Dr. Haynes. This is from an anonymous attendee, so we'll just say it's me. One day when I grow up, I would like to be the next Dr. Spain, Dr. Martin, Dr. Park, Dr. Haynes, Dr. Kalps. I want to be an academic surgeon working in an academic center doing what you guys do. Can I get that job if I just do a 1-year fellowship, or is it a little bit more nuanced than that, Dr. Kalps, Dr. Haynes?
Okay. Am I muted or
We can hear you.
okay, great. Just confirming. No. I mean, your pathway is your pathway, and I will echo what all of the panelists said is your career path is not limited by your fellowship or where you choose to go. One of the things I was told as a very young fellow, they said, this is your year to become an expert in this area. And if you take advantage of that time, and it's true for both 1-year and 2-year fellowships. I've seen people who wanted to sort of coast through they wanted to get their 1-year, they said, over with, and thankfully it's not any of our fellows. And I've seen people who coasted through 2-year fellowships. So just the length of time doesn't matter. It's what you choose to do with that time. And so that would be my comment. So no, you have opportunities available, and I'm well aware. And one of the great things, to echo what everything has been said, is ours is a wonderful community of people. We have contacts. And so I'm aware of people who've done 1-year fellowships, 2-year fellowships. It's your choice. It's your opportunity. So I'll be quiet now.
Just briefly, I would echo the same thing. I think the other part of it, and as personal bias is, we train both types of fellows here at UC San Diego for that exact reason. It's kind of a choose your own adventure, and think about the things that you want and you need and how you want to build your experience for fellowship. And those people, kind of like what I think it was Dr. Spain mentioned, people who are, or somebody mentioned about having, those people who feel confident in their skills from a surgical standpoint and don't feel like they need the extra year. There's a lot of different things that you have to think about from a personal standpoint as to what your fit is and what you need to get out of fellowship and what your next steps are. And that's where trying to pigeonhole you into one thing that every single person needs to have is not fair, because there are so many opportunities out there. So really thinking about what your next steps are, what your goals are, is really important.
Thank you, Dr. Haynes. This is another anonymous attendee. So again, this is me. I think I need some more time. I think I need 2 years. I was a little lazy. I didn't really take full advantage of residency, as most of you know. And I wasn't a particularly good resident. I'm worried about my ABSITE. I'm worried about my lack of research, but I'd really like to go after a 2-year fellowship. You know, we're very lucky to have so many of you that hold these positions, that you're looking at prospective fellows. Is there something that you're looking for specifically? Is there a phenotype? What is going to make me, despite my many shortcomings, a competitive candidate to come to all of these fantastic programs that you're representing?
I mean, I'll take a stab at this, right? Like, I think the same is true when you're applying for residency, right? Like, there's some medical students out there who've done a ton of things, and okay, great, like they're clearly driven, and there's others that maybe haven't accomplished as much, but haven't had the opportunities. And so, yeah, I don't know. I think as program directors, you're always kind of like looking at everybody, right? Like, and if you just pick the people that have already done a ton of stuff, you're going to have a certain phenotype. And, there's somebody who's like in the situation you said, like, to me, if they're honest about it and their personal letter says, hey, like, I need this opportunity. Like, I need to grow. I think you're a place that can help me grow. I think like sometimes taking on a project like that is a great thing for a program. I would be up for it.
I'll reach out.
Milos, you've decided to do a fellowship now? That's wonderful.
A couple more at least. Make up for the deficiencies.
Well, actually, to echo what was said, it's still a learning curve. I think all of us we look at this with a growth mindset. We're all still learning. And that's what makes critical care and what we do so exciting.
Yeah, and for our future prospective candidates, I think this is something that really separates our field out from all of the great specialties out there, is that the mentorship that you have is going to help you excel, not just clinically or academically, but really complete you as a person. Dr. Bavashi, Dr. Spain already sort of tackled this question, but that we have several AAST certified fellowships, and we're probably going to have more and more coming on the horizon. Is this going to be something that our prospective candidates need to chase? Is it going to offer some benefit over others? Or are we again saying, tailor your choices depending on what you think your future needs are going to be? Dr. Martin?
I think that there will probably be some future changes, but I still think that there is a lot of freedom to do what you think fits best with you and your career goals. And if there are changes down the line, like let's say a focused practice designation in acute care surgery, if you trained before that was developed, you can still apply for it retrospectively if it fits your current practice. And if it doesn't fit what you're doing in the world, then it really doesn't matter. I mean, one of the beauties of acute care surgery is just how diverse our practices can be. And you can follow what is most valuable and rewarding for you. And I don't think doing 1 versus 2 years really changes a lot of that. I think the biggest piece is really the fit. How well does a program fit with what your goals and needs are? There are some people who may want a 2-year fellowship, but they need to find a 2-year fellowship that actually fits with their goals, whether it's research or administrative training or what have you. And so thinking much more so about fit and less about where it takes you, because in the future, I think everyone's just going to be fine. No one's, not going to be able to find a job because they didn't do one fellowship over another. And I will say, just because it hasn't been said yet, there are programs out there that will tell you that doing a 2nd year is an absolute waste of time. And there are also programs that will tell you that you'll never get a job if you don't do a 2-year fellowship. just to put it out there. But I think neither of those statements are true. You know, there might be a place or two that only wants to hire 2-year fellow train, but that's their prerogative. You know, there are plenty of opportunities to find a job, regardless of what pathway you took, as long as it provided you with a reasonable skill set that allows you to do the work that you want to do.
I think that's a great point, Neil. It's like, right, like if you're at a medium volume general surgery program and your dream job is at Emory or USC, then you should probably do a 2-year fellowship, right? And the converse is true. If you're at a high volume general surgery program and have a lot of trauma experience, you know, maybe all you really need is a 1-year critical care fellowship to get that certificate and get on with life. Now, I will say, like, I've always told the residents, like, 1 year or 2, like, whatever. Like, it seems like a lot, right? But what you're talking about is the end of your career. You're taking 1 year off the end of your career. So if you do a 2-year fellowship and you want to make the same amount of money, then you're going to have to retire at 69 instead of 68. So you know, so it's the end of your career. So if that extra year lets you do what you want for that 30 years, then do it. And if it doesn't change your career trajectory, then do 1 year and be done with it, right? And you know, so if you're at a general surgery program, they're like, go do a 1-year fellowship, we'll hire you back, and that's a great job for you. Then do a 1-year fellowship. I mean, all the options are out there, and I think Niels is right. These absolutists on either side, neither one of them's right. So.
I would agree with that. The other thing I would say too is, as you look at 1-year fellowships, and I've told many people this over time, there are two sort of, whatever you want to call them, graphic equalizers of the two things. Number one is it operative or non-operative? You know, we happen to have a fellowship where the fellows are operating during that time. And the other thing is, what's the balance in that fellowship between trauma and critical care? There are some fellowships that are very trauma heavy, and others where you're doing very little trauma and mostly critical care. And so, those are the questions that you want to be asking as you're interviewing, to find that balance that works best for you.
I mean, these are phenomenal points. And one of the benefits of this fellowship town hall is that in addition to have program directors and leaders in the field, we also have fellows. And so I am by no means long out of fellowship. I am still in my attending infancy. But I think it'd be interesting to hear Dr. Hodges and Dr. O'Connor answer some of these questions. We had one question that said, how many programs should you apply to? I'll be honest, I applied during the COVID era. So for me, I applied to pretty much any program that I saw. I applied to. I had no preference. I knew exactly what I was wanting from a fellowship, but I applied to all of them because I wasn't traveling anywhere. But that's not necessarily the same anymore. So I would love to hear Dr. Hodges, Dr. O'Connor, what do you think about how many programs to apply to? What was your fellowship interview process like? I've heard that residency was more of an application for the program and the fellowship. You actually did more of the interview in the program yourself. Does that hold true? Or what are your thoughts for some of these candidates who are asking these questions?
I can go first. So, first off, I'm a first year fellow, so not that far removed from the whole match process. And you know, I went into it and I had a pretty clear picture of what I wanted. I was pretty sure I wanted a 2-year program. You know, I felt like I wanted to do probably academics afterwards, and so I felt like I wanted to leave that door open. Obviously, there's been great comments about that already. But I ended up applying to about 34 programs, most of the AAST programs, and then I picked a couple other ones that I felt like were busy operatively, and then a couple that were sort of I felt like geographically would be in easy locations, and so that was kind of how I went about it. And then, you know, the interview process obviously was mostly online, had a couple of in-person things, and balancing that as a chief resident also is another thing you have to think about. Luckily, I was a scheduling chief, so I was just on nights the whole time I interviewed and slept about 7 hours a week. But you know, I think that's something you have to keep in mind as you go through this process, because like Dr. Dilday talked about, I think more and more places have some component of their interview that may be in person, and it's certainly a worthwhile experience, obviously. That's just my bias, but
Yeah, I'm I'm probably the worst person to ask this to. I actually and I had a very trauma heavy residency. I didn't need trauma, and I actually initially applied to do transplant surgery and kind of got cold feet, if you will, and kind of backed out at the last minute. And I was just very fortunate that I had some phone calls made on my behalf, and I essentially applied to one place and had an in-person interview, and here I sit. So, and that was beyond the match. So I guess my input here is that the match is clearly important. That's how most people get their spots, but it isn't the only way to get into a fellowship position. I essentially backfilled a new spot at our program, and just got incredibly lucky. But through hard work and some important phone calls and showing that I could do the work. So I think it's important to apply to many positions, but there's other ways to do it as well.
So one fellow says 34 programs, one fellow says one program. I think we got to kick it up to the program directors. Is there a
Somewhere in
set
the middle.
number of interviews or programs they should apply to, or is there data on it that
That's
show a
like,
certain
that
number of
comes out to
interviews?
like 36 divided by 2, the average is 18. That's probably a good number.
I think that's a
I
really
think if you
individual.
just look, if you look at your odds, there's actually, for the most part, over the last few years, more spots than fellows applying. And so in general, the match rate for our fellows that we review every single year is about 96%, somewhere around there, Krista. I guess, Pauline, you presented this year, but the match rate is incredibly high. So your chances are great. It's just about finding that right fit for you. And if you need to go to a few extra interviews to do that, but I wouldn't stress yourself out that you need 50 interviews.
Yeah, I think about the numbers from the match, I think 2 years ago were about just over 50% of fellows got their first or second choice. The majority of fellows are matching. They're interviewing a lot. I think Bill Chu is on the line and he may have the SCCPDS numbers, but definitely Zoom made the number of interviews go up. But I don't know that it actually, how all the interviews contributed to where people eventually ranked.
Almost all the match data across all specialties and all programs, 12 to 15 is if you don't match in 12 to 15, you're not going to match. So more than that is really not needed.
Yeah. And if it also depends on what your situation is, your personal situation, like how much you're tied to a geographic area. But I would agree exactly what's been said. I would have said 10 to 12.
This current IMG excluded, any reservations from the panel about taking J1 visas? I think this is just a good question to ask during the interview process. In my experience, it has never been an issue, but foreign medical graduates, folks on J1 visas, is doing a 1 versus a 2-year fellowship something that raises alarm bells for you all when considering an applicant?
So I would say no. I think it's very center dependent. At my place, we have a whole office that helps us with international students and trainees. The one I think note that people need to understand is, again, within the heterogeneity of 2-year programs, if there is a 2-year program where you as a second-year fellow will be granted faculty privileges, a J1 visa is not adequate. You need to convert to an H1B or an O1. And there is a lot of time and some money involved in that process. And if you want to do a 2-year fellowship and you're thinking about doing it at some place where you need to have faculty privileges, you should at least look into what it would take to get that next visa. In terms of time, expense, if you already have a lawyer who helped you figure out the J1 visa part, it might be worth just spending a couple hours surfing Google and kind of figuring out what that would mean for you. So that's the only kind of cautionary tale I would say for folks on a visa.
Yeah, and having been through the process, just the one big caveat is you have 7 years on that J1. So if you have spent research time, if you have done something else, you have to understand that you're on borrowed time, and if you're working towards a specific goal, and if you've already had enough experience in residency, 1 versus 2 years, as we have heard, may not necessarily make or break what your future plans might be. Concerning specific tracks and the opportunities to do subsets of things in acute care surgery. I know Dr. Dilday has some questions here about robotics. We had a question in the chat about vascular surgery and whether or not there was a way to suss out where can I get more vascular experience, because I'm a military surgeon and I want to make sure that I can take care of vascular injuries when I'm out there on the battlefield. Does the panel have any insight as to how or what questions our candidates should be asking to figure out how they can start getting a little bit more experience into those sort of specific tracts of, well, I'd like to do burn, or I really want to be good at the vascular portion, or the robot is coming and I want to be able to have that in my practice?
I would say one of the things. Oh, go right
Go
ahead.
ahead. Go ahead.
Nope, you go ahead, please.
I think probably just asking the question, being honest, right? If it's something you want to do when you're on the interview trail, be honest and say, like, that was something I was looking for, is vascular trauma. And so I feel like if you can, I mean, it's not terribly gauche to ask for case numbers, but just ask a frank question. Are y'all doing your own, extremity vascular? Who's doing that? Do we rotate with vascular specifically? I think those are all perfectly valid questions to ask. And same with burn. I feel like that was a really common interview question was, where do you see yourself in 5 years? What do you want to do when you have a big girl job? And I think if the answer is I want to be a burn surgeon, and you're honest about that, if it's program worth being at, they're going to make sure you get that experience. If it's the answer is I want to be a battlefield surgeon, I want to be able to deal with vascular injuries, then if it's a program that has your best interest in mind, they're going to make that available to you.
Dr. Haynes, we may lose you to a trauma here imminently, so if we could get your input, that would be fantastic.
I think it goes back to knowing what you want and what you need and where you see yourself going, because you're not going to be happy training in a place that doesn't give you the experience in vascular trauma if you want to go work somewhere that you're going to be doing that a bunch. You need to really, and we want to train people who want the experience that we're giving. That's the other part of it. And so it goes both ways. So ask the questions. Really, this is the time to really think about yourself. You may not know for sure everything, but you know what your, for me, when I was in your shoes, it was, what are my weaknesses? What do I need? What do I need to fill my toolbox to really get started? And so think about it in that manner. And I love it when people ask me questions about, what do you have for this? Do you offer that? And really helps us to, all of us. The whole goal here is there's lots of positions. We're all trying to find the right fit with each other as far as who's going to train who and how it's going to all work out. And it seems to work out pretty well. So get to know the programs and really ask those candid questions.
And I would echo exactly what's being said. It is not rude at all to ask those sorts of things, because each program has its own strengths. You want to be in the place that will give you that experience. And I would also say, yes, ask the faculty or the program directors when you're interviewing, but also ask the fellows. I think an important part of an interview is the chance to speak with the fellows. As I always say, is look, the faculty and the program director can tell you anything they want. The fellows will give you the real deal. So I would, ask the questions.
Dr. Dilday?
Yeah, so I want to speak specific about the military component. And interesting, I'm pretty sure every single person on this call has either some exposure with military training, whether it's fellows or attendings, and some programs have embedded trauma surgeon in there. So I asked that exact same question, and that was a question that I asked on every single interview. And some programs were very honest. They said we give all of our vascular, specifically peripheral vascular trauma, to the vascular surgeons. But as someone who just got back from deployment and the way the current operative environment is going from military side, do not underestimate the surgical critical care aspect for the military community. So I know that the trauma and the vascular exposures are very relevant. As some things change, we're starting to see that the critical care aspect is becoming much more in demand and in need than we previously thought with a different battlefield environment. So don't assume that just because a trauma surgery department does not do 8 penetrating abdominal gunshot wounds that has vascular involvement a month, the critical care aspect is extremely relevant in today's military deployed climate, and most likely, some would argue, is even more relevant in the expected political climate, I should say geopolitical climate in the years to come. So remember that the critical care aspect of the fellowship is the fellowship, and the military will still give preference in terms of how they want to utilize those assets, not just from an operative standpoint, but from the all-encompassing critical care aspect. So that's a great question to ask, but by no means should it be a sole discriminator on where you're looking for a fellowship.
We'll wrap up just with this last question. Another anonymous attendee, so it's me again. I'm being forced to remediate. My skills are incredibly lacking, as Dr. Hodges will attest to, being my former resident, and they've asked me to do a 2-year instead of a 1-year fellowship. I don't have a lot of publications. Am I going to be competitive applying to your institutions if I am not, I don't have a CV with publications that span several pages?
I think every fellowship is different, and there are fellowships that will probably be perfect for that candidate. And then there will be fellowships that, throw their fellows to the fire operatively a little bit quicker. And by virtue of that, they have to select fellow candidates who maybe come from busier residencies. But then there are programs that have a lot more kind of runway, just by the layout of the program or the way the faculty practice is set up. And so I think that there's probably a fellowship out there for almost everyone. You just have to do your homework and look again for that fit. But I would say, spend the time, talk to your mentors. Have your mentors talk to their colleagues and mentors around the country to help find the type of program that would be most suited for you or this person.
I'll let Dr. Zazo know that you will consider my application. I appreciate it, sir. On behalf of the AAST, Dr. Dilday, our our associate member chair of education, the SCCPDS, Dr. Haynes and Dr. Kalbs for organizing this. A huge thank you to Dr. Spain, Dr. Park, Dr. Martin for giving a great talk and preparing the next generation of acute care surgeons, trauma surgeons, intensivists for what will no doubt be a career full of value and worth. We want to thank you for attending. We want to thank our panelists and our speakers for all of their knowledge that they have shared. We hope you have enjoyed this. We look forward to putting it on for you again next year, and we wish you all the best of luck, and I'm sure some of you will see our esteemed colleagues on the interview trail. Hopefully you'll get to see Dr. Hodges and Dr. O'Connor at their respective institutions, where you can ask them all the questions that the faculty will be unwilling to answer. So thank you so much to everybody that has attended. Thank you to our speakers and our panelists. We've enjoyed this session, and we look forward to our next grand rounds and our continued collaboration between the AAST and the SCCPDS. Thank you so much.
Thank y'all.
Thank you. Thank you.